Hi, my name is Sacha Bajala. I'm one of the ECU Nephrology Fellow, first year. And today my journal club is about bone and mineral metabolism. All right, this is the title of my article. It's bone and mineral metabolism and fibroblast growth factor 23 levels after kidney donation. This is an article that was actually published in the American Journal Kidney of Disease in June of this year. Before I go on and go into the articles, I want to give a bit of information about fibroblast growth factors. Fibroblast growth factor 23, it is a bone-derived hormone which is regulated by phosphate and calcitriol metabolism. And then it is secreted by osteocytes and osteoblasts in response to phosphate loading or increased level of calcitriol. Uh, to continue on, it reduces phosphate reabsorption in proximal tubule by downregulating the sodium phosphate co-transporters. It reduces calcitriol by inhibiting renal 1 alpha hydroxylase. This is And one thing about fibroblast growth factor 23, and this is one thing they said about in patient with late CKD, it is unable, they are unable to reduce the phosphate level. I was not able to find much reading how the mechanism work, but it's one thing that I've read and found based on my research. He said it's unable to reduce the phosphate level, but the mechanism is unclear. The other thing it does, it appears that high levels of fibroblast growth factor 23 to have some unwarranted off-target effects such as left ventricular hypertrophy, worsening of CKD progression, and premature mortality. And since last time I was supposed to have the presentation for Cloto, Dr. Cristiano did mention that I wanted to know what was the relation of Cloto and fibroblast growth factor. I decided to include one slide just to give you information about Cloto and how it is related to fibroblast growth factor. And one thing about fibroblast, it is a single pass transmembrane anti-aging protein that has been shown to have important biological effects. It is mainly expressed in kidney and in parathyroid, and it acts as a co-receptor for the fibroblast growth factor. This is really a picture like saying basically just go over everything that I've just said about fibroblast growth factor and the Cloto. So if we looked at it, it will look like, as we say here, how we have the osteocyte and the osteoblast. Osteocyte, which is one of the principal cells involved in mineralization, which actually go, and there's other protein involved, but I'm mostly going to talk about the fibroblast growth factor. Here we have the osteocyte works to release fibroblast growth factor, and fibroblast growth factor in turns coupled with the Cloto, which is the fibroblast growth factor receptor Cloto complex, which acts on the kidney to decrease the phosphate absorption, decrease vitamin D, which is 125 OHD to vitamin D synthesis. And as well, as you can see, the fibroblast growth factor increased level also can act on the parathyroid gland as well, increase PTH. And above, I also, like as already I had mentioned already, talking about factors that in turn can stimulate fibroblast growth factor 23. We have, like I already mentioned, you have phosphate loading and increased vitamin D. Those are all factors that in fact increase fibroblast growth factor level. All right, so before I go on again, and the CKD, as we all know, in many patients with moderate CKD disease and virtually all dialysis patients, they tend to increase increase in serum phosphate, I can say phosphate retention. They also will have the increased fibroblast growth factor, just have been seen in patients CKD, 4 and 5. And also they will have increased plasma intact parathyroid hormone and altered vitamin D metabolism. This is all things that we all aware that can be seen in patients of CKD. Therefore, all the things that I've just mentioned before put our CKD patient and dialysis patient at risk for having osteoporotic fractures, progressive loss of kidney function, and also cardiovascular disease due to vascular calcification, and therefore increased risk of morbidity and mortality as well. All right, so this is the background. As we see, living kidney donation offers a unique setting to study changes in phosphate and vitamin D homeostasis, which is attributed to mild isolated decrease in GFR. One thing about living kidney donors, they are heavy individuals who after given a kidney, they'll tend to experience on average decrease in GFR of 26, which is range about 8 to 50 ml per minute at 1.73 mercury after a nephrectomy. All right. So the methods for the study, basically it was a cross-sectional study that was done in 2004, from 2004 to 2008, comparing about 198 living donors and 98 non-donors control. Patients were recruited from 7 transplant centers across Canada and 2 centers in Scotland and Australia. And also, this is also about continue about the method. The previous living kidney donors were identified through patient database of participating centers. Donors, they were eligible if donated between 1970 and 2007. And once they identify the eligible candidate, they were contacted by phone. And also once they have the donors, they needed to have non-donor control. So they had a comparison group of non-donor control that was also assembled. So the non-control donors, the would-be individual who have undergone donor evaluation, therefore they will be had been deemed medically eligible to donate by the transplant team, but ultimately had not donated. Okay, so regarding the study, continue on. We had about 1,140 eligible living kidney donor identified. Among the 1,140 identified, 421 were contacted, and 235, about 56%, were consented. 198, about 47%, completed. Donors identified, 241 potential non-donors controlled, and 172 were contacted. And 98 non-donors, about 57%, completed the study. Now we're looking at table 1. Table 1 basically going over the characteristic of donors and non-donors controlled. So basically, if you're looking at it, they're basically looking at the age at the time of donation of donors and the non-donors, and then there was not much a difference, because if you see, there were 44 on the donors and 41 on the non-donors. And they look at the time, age at the time of biochemical evaluation, and basically we're looking at, they said the mean and range was about 51-49 against no difference at the time. And then they had a woman about 122 and 63 non-donors. There was some kind of a difference, but even the P was not significant here. And white was about 189 and 97. So basically, the figure 1 is basically just this is a box plot of donors and non-donors looking at the estimated glomerular filtration at the time of biochemical evaluation. If we look at let's look at the donors first. When you look at the donors, and you're looking at the GFR, basically at the time of the chemical evaluation, they had an average of about 73 and about 70s. And then if you look at basically the GFR around the time of biochemical evaluation in the non-donors was about 90, so a bit higher than the donors group. All right. So basically, this what they did, they sent out a study kit with collection tubes for blood samples and requisition, and those lab values that they really were looking at, they look at if they wanted the phosphate level, creatinine, a plasma intact PTH, calcitriol, and also an intact serum fibroblast growth factor 23. All right. So basically, the figure 2 is the scatter plot. What I just mentioned earlier, basically, it's looking at the age at the time of biochemical evaluation, looking at what was the GFR. Basically that's what they're looking at. And then, as we mentioned, as we've seen in the donor group, they were like about 44, 51. I don't remember, but this is just looking at this is pictures looking at what I've just mentioned earlier. All right, so going on to table 2. In table 2, they're looking at this is the actual biochemical measures in donors and non-donors. We have in looking at first, we're going to look at the serum calcium. When you look at the serum calcium in the donors and the non-donors group, there was really no significant, there's no difference really. If you're looking at the calcium, which is not much change, 2.21, and the donors, there was not much change. And further on, when we look at the plasma intact, there was really no, the changes weren't as much significant between the two groups, even though the plasma PTH was slightly higher in the donors. And serum phosphate was found to be much lower in the donors as compared to the non-donors. And now when we're looking at the renal fractional excretion of the phosphate, this is where we had a really big significant big difference, and you could see the difference between the donors and the non-donors group. And basically, if you look at it, it was about 17.8, almost about 18 in the donors as compared to 12, and with statistically significant p-values. Again, the serum fibroblast growth factor 23 between the donors and the non-donors, which is was significant, was 38.1 as compared to 29.7, with a p-value of significant value, statistically significant value. Serum calcidiol really was definitely, like you say, it was higher from non-donors, not a significant p. And the serum calcitriol, that's the one when we see was much lower in the donors group as compared to the non-donors, with p values, statistically significant p values. All right, so the figure 3, which is a box plot, basically this is looking at what I just mentioned, at what I really just mentioned just now in table 2. Is basically looking at, if we're looking at the phosphate as what I just mentioned, which was much lower than the non-donors, and looking the fractional excretion of phosphate, which was much higher, and which was significant between the two groups. And then again, looking at fibroblast growth factor, which was again much higher in the donors compared to non-donors, with a significant difference. And looking at calcitriol, which was much lower in donors compared to the non-donors, like we saw again in table 2, which was a very significant difference with a significant p-value. All right. So basically, what we are looking at now, table 3. Table 3 is basically looking at the biochemical measures in donors and non-donors by GFR category, which is actually described by the all right. So now what we do, we're looking at table 3, which is basically looking at the biochemical measures in donors and non-donors controlled by GFR. Those are biochemical measures by CKD stage as defined by the Kidoki. Basically, this is what that's what we're looking at. Alright. So in the donors group, if we're looking at the GFR greater than 90, which is about 14% of patients of the donors group. And then if you're looking at the non-donors group, which is about 72% of the non-donors group are in this category. Basically, if like we already mentioned, looking at the different value, what I'm going to do, I'm going to look at the donors by category. Okay. So when we go back again, I already mentioned the donors groups about 14% of that, and about the 30 to 59 about 18% of the group. So what we look at, I'm going to look at go to the renal fractional excretion of phosphate. What we see, if we look at in the GFR greater than 90, and if we look across as the GFR is decreasing, and we see there is an increase value, like the fractional excretion is actually increasing. And the other thing also in creatinine, in the serum creatinine, there is also an increase of that as well, and in which with significant p-value. Going back, I'm sorry. Again, the other thing you also can also look at for the serum FGF-23 in GFR greater than 90 and going across 60 to 89 as the GFR is actually worsening, and you can see the increase in the serum fibroblast growth factor FGF-23. The other thing, again, if you looked at the serum calcitriol, as we go across here, that we see the decrease. We see like in GFR 90 greater than 90, there is a decrease of 73, and it's progressively is going down as GFR is also going down. As we go down onto the non-donors group, as you can see, the first thing you'll look at, you'll see there is no one in that category with a GFR of 30 to 59. So same thing, looking at the serum, the renal fractional excretion of phosphate, which is same thing, it's going up as GFR is decreasing. Looking at the serum calcitriol going down as GFR is decreasing. Alright, table 4 is basically looking at the relationship of the fibroblast growth factor 23 with the fractional excretion of phosphate, serum phosphate, and serum calcitriol. Basically, what we're looking at, if we're looking at the table 4, the renal fractional excretion of phosphate, we saw as the fibroblast growth factor is increasing, the renal fractional excretion of phosphate is also increasing, telling you that there was a positive correlation between these two. And also, what we're seeing is that and then going back to the article, if you do have the article, and you also will see there was a positive correlation with an R of 0.15 with a confidence interval of 95% and then of the 0.02 to 0.38 with a p-value of 0.003. And going down to the serum calcitriol, what we see as the fibroblast growth factor is increasing, and the serum calcitriol is actually going down, which was very significant with a p-value statistically significant. So telling you there was a negative correlation between the two, between the fibroblast growth factor and the calcitriol. Basically, going into the discussion, what we see, nephrectomy did impart some mild isolated decrease in kidney function in donors. The lower estimated GFR in past kidney donors observed compared with non-donor control. And we saw there's a higher serum FGF-23 levels, higher fractional excretion of urinary excretion of phosphate in the past kidney donors compared to the non-donors. And the other thing, like which we've seen in the different tables that I've shown, lower serum phosphate and calcitriol observing donors, calcium level not different between donors and non-donors, and we saw there is plasma intact found higher in donors compared to the non-donors. And the fibroblast growth factor 23 level was higher early in the course of decreasing kidney function. And before I finish, I actually was able to find there was a study, which is a clinical study, which was the fibroblast growth factor and minimal metabolism parameters among prevalent kidney transplant patients. It was actually published in an international journal of nephrology in April of 2012. That was a cross-sectional study of 106 kidney transplants that was actually enrolled at Tufts Medical Center from November 2005 to October 2009. While it showed it was fibroblast growth factor 23 were above the reference limits in 7% of patients, and fibroblast growth factor 23 appeared to remain important driver of minimal metabolism in prevalent transplant patients. They actually look at other laboratory levels, which I mentioned in the article that I just presented, but I just basically just probably included about the FGF-23. Thank you. Questions?